Hmm. All right, who do we have on from the board?
I'm looking now with you, President Thomas. This is Camille. I'm not sure. There is member Hinman just came on. Members Harrison and McKinley. I do not know if those are their phone numbers. Are you present, member Harrison or member McKinley? And
this is member Fagan. I just came on. I'm trying to
Thank you,
get
Doctor.
the Teams link up. Yeah.
No, apologies. This is Camille. Thank you, Dr. Fagan. There is member McMillan. Awesome.
I think I just said some things and realized I was on mute. I'm here. There was an extra hurdle to get into the meeting tonight, so I apologize for being a minute late here, but I'm here. Thanks.
Okay. Well, it looks like we do have a quorum. So with that, I will go ahead and convene this regular meeting of the Boulder County Board of Health, called to order at 5:32 p.m. on Monday, November 8th, 2021. And let's see, this meeting is being called to order, and we are holding it telephonically due to the COVID-19 pandemic. And so we've been doing this for well over a year now, and we will continue that way for a little while longer. So can I have the board members introduce themselves? I'm Greg Thomas, board president.
This is Landry Fagan, board member.
Brooke Harrison, board member.
Lindy Hinman, board member.
Morgan McMillan, board member.
And vice president.
And vice president.
Okay. All right, let's see here. We generally start off our meeting with public comment. And the way we've been doing this is people sign up in advance based on the notice of the meeting. And then we go through that list. Kate, you have been helping us through that process for the last several meetings. Assume that is okay to continue?
Yeah, absolutely. Don't fix it if it ain't broke. All right, so Mark Bowen, if you are on the meeting and would like to make a comment, Mark Bowen. Okay, we'll move on. He did submit a written comment for the board's consideration. Ryan Snow. Are you on the call, Ryan Snow?
Hi, this is Ryan.
Hi, Ryan. Would you like to make a statement? You would have 3 minutes, or we can just rely on your written comment.
Yes, I would. Thank you.
Okay, great. Your 3 minutes can start now.
Okay, yeah, I would like to just speak. I grew up in Boulder. I work in Boulder, own a business in Boulder, and I've kind of seen how Boulder County public health's mask mandate has been very adversely affecting local businesses across the state. People are very fatigued by this effort, and I think the data points that you've been drawing on to make this decision are extremely weak. I think if you were to compare Boulder to another city in a different state that has no mask mandates, you would not be able to find a clear correlation between the effectiveness of masks and controlling disease spread or COVID otherwise. So I'm very much against this current mask mandate. I think it's despicable. Going out in Denver, gave light just the positivity when people can greet each other with a smile, and you've taken that away from all these Boulder residents. I think the vaccine verification program is utterly disgusting as well. This is what everyone worldwide is actively protesting against. If you look in other countries, if you look across the state of New York, they are doing marches against this exact thing. So to incentivize 100% vaccine uptake in Boulder and do it on a business level, I think is entirely wrong. There's no COVID health emergency in children 5 to 11, so that was a sad decision to see that. And we clearly know at this point, if you look at any sort of data set, such as Israel, or if you look to any other Iceland, highly vaccinated population, the vaccine does not stop infection, transmission, hospitalization, or death. Therefore, it should not be, and is overwhelmingly affecting those over the age of 75 and those who are morbidly obese and already have pre-existing health conditions. So to simply thrust something on a healthy population and across the board, if you were to look at deaths, as you likely already know on CDC data, it's greatly skewed. So I'm very, very disappointed that you're using a low case threshold that has seemingly shifted lower than what it was back in May when you first released that criteria. And I apologize because I turned my camera on right now, but it would be great to see you in person. And I think not meeting under the guise of COVID, that simply doesn't hold up very well now. So all in all, I think that you should end this mask mandate definitively. I think you're hurting and harming businesses. I've decided to take my business elsewhere than go to Boulder and have to deal with it. And I think it's just terrible. And I think it's terrible how we pretend like kids are at risk when it's hardly even quantifiable, and we want them to get this vaccine. And there's an emerging body of evidence that shows that the efficacy of these vaccines lasts no longer than 6 months.
Your time is up. Thank you.
Boosters. Thank you.
Thank you. Is Andrew Alexander on the meeting?
Yes, I'm here.
Great. Would you like to speak?
Yeah. So,
okay. I mean, great. Your 3 minutes starts now.
I largely echo what the previous caller says. I think Boulder Public Health is doing a very poor job. But after listening to and reading the transcript of the board meeting, I feel there's a lack of critical thinking at the board. I actually have a view that there's actually more to the world than just pursuing zero COVID. And, we can't let scientists run our lives because it's clear you guys are just risk minimizing, risk averse bureaucrats. So rather than appeal to the data, which is obviously clear that COVID is not that dangerous and the mask mandate should not be held, I'm just going to read some C.S. Lewis. And as I read this, I want everyone to replace the word atomic bomb with COVID. So here goes. In one way, we think a deal too much of the atomic bomb. How are we to live in an atomic age? I am tempted to reply, why? As you would have lived in the 16th century when the plague visited London almost every year, or as you would have lived in a Viking age when raiders from Scandinavia might land and cut your throat any night, or indeed as you are already living in an age of cancer, an age of syphilis, an age of paralysis, an age of air raids, an age of railway accidents, and an age of motor accidents. In other words, do not let us begin exaggerating the novelty of our situation. Believe me, dear sir or madam, you and all whom you love were already sentenced to death before the atomic bomb was invented. And quite a high percentage of us were going to die in unpleasant ways. We had indeed one very great advantage over our ancestors, aesthetics. But we had that still. It is perfectly ridiculous to go about whimpering and drawing long faces because the scientists have added one more chance of painful and premature death to a world in which already bristled with such chances and which death itself was not a chance at all, but a certainty. So this is the first point to be made. And the first action taken is to pull ourselves together. If we are all going to be destroyed by an atomic bomb, let the bomb, when it comes, find us doing sensible and human things. Praying, working, teaching, reading, listening to music, bathing the children, playing tennis, chatting, to our friends over a pint and a game of darts, not huddled together like frightened sheep and thinking about bombs. That may break our bodies, but they need not dominate our minds. Thank you.
Great, thank you. And that is the last public comment.
Okay, item 2 on the agenda. Thank you for those comments. Item 2 on the agenda is the approval of the October regular board meeting minutes.
This is Morgan. I've moved to approve the October board meeting minutes.
This is Brooke, I second.
Okay, we have a motion and a second. All in favor?
Aye.
Aye. Aye.
Okay, I'm having a problem right now with my accessing my agenda.
I can help you, President Thomas, if that's okay with you. This is Camille.
Yeah, I should be back up in a minute or so, but
no worries. I can take it from here. You would have actually just handed it over to me anyway for a presentation from our staff. I thank the Board of Health for your attention this evening. Thank you to all BCPH staff in attendance, whether or not you're contributing to this presentation tonight. What we will be doing for you this evening is really giving you an overview for situational awareness and trends relative to COVID-19, some of the policy developments that have occurred since our last meeting, and then our Boulder County Public Health response from an epidemiological, vaccination and vaccination equity perspective. We know that you gave a considerable amount of time about a month ago, so we are thankful for your time. And this presentation should not be as long, but it's definitely as robust. And so without further ado, I will turn it over to Dr. Lexi Nolan, and she will begin us on this journey. And again, thanks in advance and much gratitude and appreciation to the staff who put this together and who are contributing this evening. Dr. Nolan.
Thank you. Good evening, board members. This evening, as Director Rodriguez mentioned, I'll be providing you with situational awareness and trends on the pandemic in both Colorado and Boulder County. Trina Ruland, our Deputy County Attorney, will provide an update on policy at multiple levels, and Carol Helwig, Keith Rawls, and Carrie Middleton will let you know how BCPH is taking action. Just a review of our 3 goals and a quick summary. Goal number 1 is to prevent severe illness and death. We are happy to say that transmission is lower in Boulder County than in surrounding counties. At the same time, we are seeing an unusual number of deaths over the past 6 weeks, but the Boulder County death rate is still much lower than Colorado and the US. Our second goal, to not overwhelm the health system, is not proving very successful at the moment. Boulder County is among counties contributing the fewest number of patients to hospitals. So as a county, we have definitely done our part. And our vaccination rate of among 75 and older is 99%. Our gap in vaccinations is the youth, but this is also our lowest risk of hospitalizations. However, further in the presentation, you will begin to see that we are having some significant strain on our health system. And third, safely returning to normal activities. We can continue to say that school quarantines are way down and our child rates are lower than most counties because of our layered mitigation strategies, but we are seeing significantly increased case rates, particularly among the 6 to 11 population. Also mentioned that the vaccine verification program which is a completely voluntary program at the option of all of our local businesses, is continuing to offer safer options to patrons and support businesses that serve more risk-averse groups so that they can encourage them to come out and participate in those normal activities. The key messages for tonight's presentation include that Boulder County is faring better than nearby counties, but experiencing a similar surge as the rest of Colorado, and we estimate that about 1 in 48 Coloradans are currently infectious. Metro County cases are still rising. Hospitals and other providers are under significant strain due to a combination of COVID and non-COVID cases, including increased trauma, delayed urgent care, and staffing shortages. And it's also really important to remember that this stress on hospitals and hospital systems and healthcare providers doesn't just affect how we can handle hospitalized patients. It has ripple effects that affect the infrastructure and availability of staff to support vaccine rollout and flu clinics, among other kinds of activities that are important for containment. We are, as we've heard before, increasingly seeing this as a pandemic of the unvaccinated. And we do have some current projections. I have highlighted this in red because I'm just noting that this was a question among board members from a previous meeting about asking for information on more projections. We are projecting cases to peak in early December and hospitalizations in mid-December. We do have some additional concerns around flu, the upcoming holidays, and resumed international travel. Our spaces for optimism include that the 5 to 11-year-old age group is now getting vaccinated and boosters are also rolling out. And we are seeing increasing employer vaccination mandates, which should help reduce transmission. And at this point, we do not anticipate changing the Boulder County public health orders until at least January, based on the data that we're seeing in the community and recommendations from the state. So if we look at cases, the first slide I'm going to show you is where we sat in Colorado in relation to other states in the United States last month. So this was from October. You'll see that Colorado was right down here. And at the time, Boulder County was fared a bit better. And if we take that same graph and we look at this month, what we see is that Boulder County is now way up here. And Boulder County is still somewhat better off, but quite different from where we were last month. And if we hadn't moved at all, if our case rate hadn't changed at all, we would still be up around this middle spot. And it's because what we're seeing is a significant decline in cases in an awful lot of states in the United States. So that's part of the answer. And part of the answer is that our case rate is significantly surging right now. So it's a combination. So we've also really tried to look in why are we having this surge in Colorado, and to date, it is not entirely clear. We have some hypotheses about what some of the factors could be, and it's likely to be a combination of factors. But the truth is that most of these characteristics are not significantly different from other states. And so it's really not clear why we are seeing our case numbers go up significantly while so many other states' cases are not going up, and in fact are going down. And it may be a cyclical factor. We often see Colorado out of cycle with a lot of the rest of the US. And so when our cases are down, cases in a lot of other states have been up historically. And so there just may be something about the Colorado population that is off cycle too, that we're just not able to understand quite yet. So this is our 7-day cumulative number of cases per 100,000. You'll remember that this red line indicates the CDC's high transmission level. The orange line is substantial transmission. The yellow line is moderate transmission and also represents, for the most part, where our epidemiology team begins to work in surge capacity. And we are currently at 269 7-day cumulative cases per 100,000, which is significantly above where we were last week. And is certainly going in the wrong direction and not seeming to slow. This is very much in step with what we're seeing across the state right now. If we look at Boulder County in relation to surrounding counties, you'll see that the whole state is pretty much in red. There's one county that is now in that orange level. Of note, although you'll see that some counties on the right-hand side have seen declining rates per 100,000 over the last week, most of those declines have been less than 10%, a small proportion, and many of the increases have been quite significant. So the amount coming down when we see that is not terribly large, and we are seeing some significant increases in some counties. If we look at our 7-day incidence trends broken out by age, you'll see that our 0 to 11 population is the age group that is having the most significant number of cases and quite a steep increase in case numbers. I think, as you all know, our 5 to 11 population began to be vaccinated just within the last few days. We're very happy about that. We hope that we begin to see over the coming weeks that number decline significantly, but even so, we still have rising rates among a number of other age groups, and our case rates are significantly higher than they were even a couple of weeks ago. If we look at the geographical distribution, we see that about 40% of our cases are in Longmont, which represents about 30% of the county population. And we are seeing that the other interesting number is that this 21% of other municipalities in unincorporated Boulder County, which represents about 18% of the population. We are continuing to see a disproportionately low number of cases in the city of Boulder and in Lafayette, Louisville, and Superior. If we look at the breakout by race and ethnicity, we see that we are close to being in the proportionate range for white non-Hispanic folks. We are seeing a slightly increased disproportionate rate of cases among Hispanic and Latinx folks, and a slightly lower than proportionate rate among other races. Our 7-day positivity continues to increase. It's now at 6.7%. And just to make a mention that our testing numbers have increased significantly in the last week, which is good. That means people are paying attention to what's happening in the community and hopefully going to get more testing. And unfortunately, we have seen a disproportionate increased number of deaths recently, most of which were not associated with long-term care facilities, but a few were. This brings us to a total of 36 deaths since May of 2021. And we are still noting that our death rate in Boulder County is substantially below the state death rate and the U.S. death rate. So this is just a similar demonstration of how we are exceeding our epidemiology team capacity and have moved into surge response, which creates a prioritization of cases that you'll hear a little bit more about in a few minutes. In terms of hospitalizations, the state hospitalization is such that we have less than 1,000 beds open across the state and less than 100 ICU beds open across the state. We're projecting 15,000 more COVID hospitalizations and 2,000 more deaths in Colorado by the end of February. And there have been several state actions, which Trina will mention in just a minute. A little more locally in our North Central Region Hospital region, our staffed ICU bed availability is at 7%. The medical surgical bed availability is at 7%, and 37% of our hospitals are reporting tight staffing. We are now at Combined Hospital Transfer Center Plan activated at level 3, and we have 19 pediatric confirmed cases of COVID-19. This shows you a little bit of a time trend of Boulder County specific hospitalizations. So you can see how the increase is beginning to reach the levels that we saw last December, with 92 patients currently hospitalized for COVID-19. And this graph shows a comparison of the availability of medical surgical beds in the purple graph and ICU beds in the blue graph. And in Boulder County today, we have 6 ICU beds available. This just is a little bit more information on the time trend comparing Boulder County and Colorado, so it largely mimics it. We are beginning to see some additional action taken by the healthcare system in terms of both communicating their message more aggressively of what folks need to do to support having a strong health system, and making personal appeals through advertisements in social media and other digital media, as well as on television and radio. We are seeing some state policy and executive order changes, which Trina will describe more in a minute. We are also seeing mechanisms to expedite discharges and transfers. Part of moving to Tier 3 in the hospital system is that the state coordinates transfers among hospitals according to resources based on the needs across the entire state. So patients are being transferred more often to ensure that they are matched to a hospital that can best meet their resource needs and that allows the system as a whole to address as many patients as possible. The state is currently working very hard to roll out monoclonal antibody treatments, which are projected to be able to reduce hospitalizations by 13 to 23% during the peak. It will take some weeks to finish scaling up this response. And we plan, we are hopeful to see 2 emergency use authorizations for 2 different pills that are early data shows cut severe illness and hospitalizations.
Hey, Lexi, sorry, before you move off of that slide, the figures that you gave earlier in the presentation that estimated 15,000 additional hospitalizations and 2,000 additional deaths in Colorado between now and February, does that not take into account this rollout that might reduce hospitalizations by 13 to 23%?
Great question. It does not take them into account.
Okay, thank you.
Okay, so turning over to vaccinations for a minute. If we look at—
Can I ask a few questions on the previous bit?
Sure.
Just so curious. This is Brooke. So first, talking about following guidance from the state, could you speak to why the state has not implemented a mask mandate, since it's only 4 or 6 counties that have actually instituted one again in the state of Colorado?
We'll talk a little bit more about what the state has done in a few minutes, but in response to your specific question, the state cites some particular studies that they believe support the position that a statewide mask mandate would not be effective. But I think that there are quite a few folks that dissent with that opinion, but to date, the state is working on a number of other kinds of interventions to try to mitigate cases and support the health system in particular. That seems to be their focus right now.
Got it. So are the studies that they're referencing, are they more in the idea that a mandate coming down from the state, there's resistance to it and it's ineffective? Or are they citing studies like the recent study that came out of Afghanistan hospitals?
I can get back to you on the specifics of why they believe those studies don't demonstrate effectiveness. I will be reporting their position on that, not necessarily a counter perspective. But I'm happy to get back to you on that.
Okay.
I would have to dig a little bit deeper into the specifics because there have been an awful lot of conversations in that space lately. So I would have to get back to you.
Okay, just curious going forward. I also had a question. So talking about the cyclic nature of it and Colorado trailing, do we have any idea of exposure rates compared across the country? And I'm not saying that I'm advocating for this, but when you look at states like Florida and Texas that basically did nothing, and now they're quite low. I'm just curious if they had a much higher exposure rate a higher exposure rate than what we've had prior to this mask mandate, and maybe now we're just catching up. And also, it would be interesting to look some at death rate, between Florida and Texas, who basically did nothing, and Colorado that's doing quite a bit.
Right. I'm happy to get back to you on both of those issues. I am not in a position to answer them at this particular minute, but I'm happy we can take a look at that and get back to you.
Thank you.
Lexi, this is Greg. Do the monoclonal antibody treatments, does that not include I'm assuming that does not include what might happen with the Pfizer or the Merck pills that are also intended to minimize severe cases and hospitalization if administered after a positive test?
Do you mean the projected reduction in hospitalizations?
Yeah. Does that include if those pills are approved?
No.
It's only for monoclonal antibodies, which is its own treatment.
That's
okay.
Correct.
Cool. Yeah. Thanks.
Okay. I'll move on if there aren't any more questions. Okay, COVID-19 vaccinations among Boulder County residents. We are happy to be able to add to our list of ages this week, 5 to 11, and you'll see already that 5% of that population has had a partial course of has had their first dose, basically, is what we're saying. We continue to have a focus on 18 to 30-year-olds in terms of trying to get those numbers a little bit higher. All of our other age groups are doing very well, so we're really happy about that, and really going to be focusing in on boosters for the most vulnerable, our 5 to 11 group, and working overtime to try to get these numbers for the 18 to 30-year-olds a bit higher. And we'll have some more information on what those efforts look like in a minute. So this is our updated graph on the percent of the population that is vaccinated. And what you'll probably notice here, or you may not notice, I'll point it out for you, is that because our eligible population number has increased with the addition of 5 to 11 population, the percentages in the full course vaccinated and the partial course vaccinated have gone down just a little bit. We continue to slowly increase this percent of the total population vaccinated, but it is still fairly flat. We are hoping that with the 5 to 11-year-olds rolling out, that we will begin to see that number increase in pace a little bit. Just a note, we do have some early information on boosters for older adults in Boulder County. Thanks to our team for working hard to get this together in preparation for the presentation this evening. But what we are seeing is that approximately 36-37% of our 60 to 69-year-olds who are fully vaccinated have now also gotten a booster. And you'll notice that 85% of that total, 86% of that total population has been fully vaccinated. So 36.6% of that 85% has now gotten the booster. And our 70 plus population, which was at 98.3% vaccinated, about half, a little over half of them have gotten their booster. And that's terrific. And we did isolate those two age groups because the booster is most important for those older age groups, because that is where we see the most breakthrough cases, the most increased risk for hospitalizations, and the most increased risk for deaths. And in fact, the chance of hospitalization and death increases substantially for folks over 80 if they don't get the boosters. And so the boosters have been quite helpful in protecting that population. So that's the end of my presentation. I'll turn it over to Trina unless there are additional questions about this section.
I have one quick question. This is Brooke again. Are there any supply concerns at this point now that 5 to 11s are eligible and people are moving to get boosters? It's going to take a little bit of patience for everything to get in the right places. There aren't significant concerns about supplies. We have heard of counties over the last weekend blazing through their doses for kids, and they're waiting for their next allocation, but we are not hearing about delays in deliveries of allocation. So at this point, I would say there is not a concern about supply. Thank you.
Thanks, Lexi, for the presentation. I have just two follow-up things. One is, do we know demographics on the currently hospitalized in Boulder County? Just that we believe it skews older, but do we know what the vaccination status is?
I will have to get back to you on that one.
Okay, thank you. Sorry, we're giving you so much homework in between meetings
right
here, Lexi. And then the other, this is more of a comment because I know that I saw some notes in the director's report, but just about the rollout of vaccines to 5 to 11-year-olds and thinking about equity and how we really center equity in our outreach and mobilization for kid vaccines. So I know that that is something that BCPH's team is working on, and I just want to emphasize the board's support for centering equity in that work.
Thanks very much, and we're happy to talk a little bit more about what we're doing in that space in just a few minutes. All right, I'll turn it over to Trina. Oh, I'm sorry, was there another question?
This is a completely random question, and I'm just curious. I know that all of our information on vaccines becoming less efficacious at about 6 months for 65 plus, 70 plus, all came out of mostly that Israel data set. I'm just curious if the state is collecting any information on that, if they're measuring any antibody titers.
They are looking at proportions of age groups that are currently represented in hospitalized populations, and they are seeing very much the same patterns. I can provide additional data if you'd like.
Only if it's easy to send it to me. Thank you.
Trina, may I turn it over to you?
Please. I'm going to spend a few slides covering the local, state, and federal policy and legal contexts we've seen a lot of movement in the last month, so bear with me, and please pause me if you have any questions or you'd like more information about any particular point. Lexi, can you move the slide forward? Thanks. So just a reminder, our school mask order has been in effect since August 9th of this year, and that is in effect until rescinded. On September 2nd, we put the universal indoor mask order into effect, and as a reminder, that will no longer require masks on its own terms once we move down into moderate or low transmission after a 21-day period. On October 29th, which was a little over a week ago, Boulder County Public Health put forth a public health advisory because, as the data that Lexi showed you, we are in surge conditions, specifically with respect to our hospital capacity around the state and locally. We made 2 recommendations. We recommended moving indoor gatherings outdoors whenever possible, and we recommended that if you are in a crowd around people from different households, you should wear a mask. And both of those are following CDC recommendations, so there's nothing new or novel there. It's really meant to be an advisory so the public is aware of what is going on. Next slide, please. Our business team continues to work with our businesses, both around enforcement issues concerning masks, as well as to respond to the vaccine verification program. The vaccine verification program, we've had 288 applications, of which 241 have been approved. The remaining 40 or so are just in the approval process still. At various stages, and there's actually a publicly available list of all of the facilities and a brief description of what those facilities are. They really range all over the place, and we're really happy that we've had so much interest in this from our business community. Next slide. Our neighbors and our local municipalities have also been taking action. Denver has a vaccine requirement that they put in place via a public health order. Our municipalities, Boulder County, City of Boulder, Longmont, and several others, I'm sorry I don't have them up here, have all made vaccines mandatory for their employees. We also still continue to have school mask requirements around the state put in place both by local public health agencies as well as many school districts stepping up to do that work. Next slide. Here's what's going on the state level. About 2 weeks ago, the governor outlined his plan for addressing this surge in cases that are appearing in our hospitals. And as Lexi mentioned, it is mostly due to the unvaccinated, about 80% unvaccinated. And so his plan is really to keep our hospital capacity at manageable levels so that those who need care can get care in a timely manner. All of the things that he outlined, there were 5 of them, have almost all been put completely in place. FEMA medical surge teams have been requested from FEMA directly. The governor implemented CDPHE order 2021-02, which delays cosmetic surgeries. He has not yet delayed elective surgeries, but has indicated that could be coming. There is legal framework in place now for hospitals to request to go to crisis standards of care. That's via Executive Order 2021-136. This is put in place when hospitals cannot manage the number of patients that they have, and they need to triage at a higher level to determine, for example, who might receive a ventilator and who won't. It's a little bit of a scary situation, but the legal framework is there for when we need it. The governor also put into place a patient admission and transfer order. And what that does is it load balances our hospital capacity around the state. Without this order, there can be some barriers to transferring patients, for example, due to insurance requirements. This eliminates those barriers so that we can make sure that we are using all of our resources on a statewide level. This order also allows hospitals to deny admission to certain folks and send them to other facilities if necessary because their hospital capacity is so stretched. The governor also had the state release a HON to healthcare providers indicating how monoclonal antibodies should be distributed for what populations, and the state is ramping up efforts around that. The state also and MDPH also followed Boulder County Public Health lead and issued a public health advisory around our limited hospital capacity moving forward. In addition to these things that have already been done, we can expect to see even more along all of these lines, as well as what I mentioned before, elective surgeries. There's potential that that could be delayed too, although the governor has not issued that specific order yet. On the federal level, there's been a lot of movements as well. OSHA went ahead and issued the rule per the president's directive that employers with 100 plus employees be required to vaccinate by January 4th, and unvaccinated employees must mask and test once per week. This affects 84 million workers. There was an immediate legal challenge to this requirement, and that's why there's an asterisk there after employees. The Fifth Circuit has temporarily stayed the enforcement of this order to determine whether OSHA is in fact the right entity to issue this order. We're closely following that. It's kind of expected there's going to be legal challenges to any of these. And we'll see how that plays out. But I will say many large companies have already implemented vaccine mandates in anticipation of this OSHA rule. Separate from the OSHA rule, the federal workforce, including the military, now has a vaccination requirement by November 22nd. There is no test out options. The only thing that's permitted are the legally required exemptions, which are religious and medical under Title VII. And there's a requirement for vaccination among federal contractors. And just to put a little more context around this, federal contractors does include companies, for example, like airlines, large airlines who do work with the feds. So this actually ends up covering quite a few people. I wasn't able to get an estimate of the number of folks that this would cover, but it's a pretty large group. In addition to that, there's going to be 17 million workers covered by the Medicare and Medicaid requirement for healthcare facilities. They must be vaccinated by January 4th. Once again, no test out option. I'll also add that the OSHA rule is interesting because it's led the way in answering some questions around that testing out requirement. The OSHA rule does not require employers to pay for testing, for that once per week testing for unvaccinated employees. It does include paid time off to get the vaccine for employees who do get vaccinated. Next slide, please. Some more about what we're seeing in the courts. The Jefferson County mask mandate was challenged. Their school mask mandate was challenged on religious grounds. The district court in Jefferson County upheld the mask mandate against those religious challenges, and the mask mandate as written by Jefferson County for schools still stands. I'm sure you've also heard some of the chatter around the Douglas County school mask mandate. The legal aspects are actually pretty interesting around that. The federal district court granted a preliminary injunction ordering that Douglas County cannot, or maybe perhaps should not, permit a personal exemption to the mask requirement in schools because allowing those personal exemptions can violate the rights of students with disabilities. It was an interesting order to read, and I think it alerted a lot of other school districts to the importance of not only having a mask requirement, but of enforcing that in a manner that's going to most protect our vulnerable populations. We've seen a number of challenges to the vaccine mandate, or to various vaccine mandates. Vaccine mandates by employers, vaccine mandates by universities, by governments. This is not unexpected. Once again, whenever there's changes, we would expect legal challenges, but they've played out pretty much the same across the board. religious challenges on constitutional grounds have been largely unsuccessful. You do see the religious exception in employment context. That's because Title VII, which is a statutory requirement, can require certain employers to have a religious exemption for vaccine requirements. But the courts have largely said there is no constitutional right to a religious exemption for a vaccine mandate. We've also seen the US Supreme Court upholding vaccine mandates in various contexts. It's upheld it in the employer context. That's the New York City teacher vaccine mandate case. It's upheld it in a university context, and it's upheld it in a public health order context. That was the challenge to the Maine healthcare worker mandate. The caveat there is the Fifth Circuit. That seems to be the most interesting thing in the legal world right now. Then that's just looking at OSHA jurisdictional issues. Should OSHA issue this rule? Should it go to Congress? I think I mentioned this earlier, but it's worth reiterating. We are seeing many employers requiring vaccines on their own. And interestingly, we are not seeing the type of exodus of employees due to vaccine mandates that was originally feared. It appears that the requirements are largely working. Some states have already declared that being fired for failing to get vaccinated means that you are not entitled to unemployment benefits. So if you refuse to vaccinate and your employer takes action against you and fires you for cause, you cannot then go claim unemployment benefits. I expect this will have some significant impacts on decisions to get vaccinated. And we are also starting to see that in some industries, for example, teaching and healthcare, it may become very difficult to get a new job in those industries without being vaccinated due to this complex network of vaccine requirements. And I will pass it off for a further discussion about the BCPH response to this surge, unless there are other questions.
Sorry, this is Brooke again. Another question. So some of these challenges are coming out a bit differently than challenges to vaccine exemptions have in the past. Has there been any discussion about how the ruling out of religious exemptions could affect other vaccination programs in the future?
So I'm not quite sure I follow you on that. Maybe I can clarify that a little, the religious exemption part a little more.
Yeah, can you maybe clarify that? Because what I was seeing and what I heard from the slide was that they're saying that there is not a religious grounds for exemption for the COVID vaccination, which is not the same as what we hear for other vaccines in the past.
So it's really going to depend on the context and who's requiring the vaccination. Title VII is what most people hear about, and Title VII requires that employers provide a religious exemption for vaccines. That has not changed. So if you're an employer and you want a vaccine mandate and you're subject to Title VII, you're going to be subject to that rule as well. What the courts have never really spoken on, and there's just never really been case law on, is whether or not the Constitution requires a religious exemption to vaccine when a government or a non-employer entity makes a vaccine mandate. And that's what we're seeing play out. So the example I was given, one of the things I had on the slide there was Maine as a state issued a public health order saying that all healthcare workers must be vaccinated, and the only exemption is for medical reasons. Now, the state of Maine as a governmental entity is not subject to Title VII in issuing the public health order. And so it was challenged only on constitutional grounds because Title VII didn't really apply. And the First Circuit found that the order was valid and the Constitution did not require a religious exemption to the vaccine. And the Supreme Court upheld that rule, at least on a preliminary matter. Does that help?
Got it. So are schools subject to Title VII? I think it's fascinating because this is quite a change then from previous rulings on religious exemptions. So I'm just curious.
Yeah, I would be careful because I don't think it's actually a change. The status of the law has been very clear for a long time. I think it's just playing out differently because we haven't been in a pandemic in a very long time. And this is the first time we've had a vaccine this quickly And it's the first opportunity this kind of issue has gotten to go to the court. So, I don't think the law has changed. It's more a matter of we're just seeing challenges that we haven't seen before. In the school context, CDPHE Board of Health governs the vaccines that are required in schools, and there are statutory requirements in Colorado for what exemptions apply. So in Colorado, at least, the constitutional issues have not played out because there are statutory exemptions that have to go into effect. And I don't want to quote them directly off the top of my head, but each state is very different in what's required in schools because it's all set by statute. And, some state might have religious, some state might have personal. I imagine all of them have medical because that only makes sense, but it's really going to depend state by state and it's set by statute for schools.
Got it. Thank you.
Thank you. If there's no questions for Trina, I'm happy to continue with the next portion of the presentation. Lexi, if you could do the next slide. I'm Carol Helwig with the Communicable Disease and Emergency Management Division. I oversee the Communicable Disease Program and the COVID epidemiology team. Prior to the pandemic, we had two full-time epidemiologists responding to all reportable communicable diseases and conditions. They're both still with us now. And now we also have on the COVID epidemiology team over 40 people, including 6 teams led by epidemiologists and a 7th team that provides resource navigation and call center services. We have developed a strategic operations plan that shifts to align with the conditions that we're experiencing. During surge conditions, we implement a tiered prioritization approach to identify cases associated with priority groups. The priority groups are modeled on the priority populations guidance that was developed collaboratively with our Metro Denver partners early on in the pandemic. One priority group strategy that we implement is ensuring that a minimum of 50% of our case investigators are bilingual, bicultural, Hispanic, Latinx, Spanish speakers. We're currently at over 60% at this time. We have 4 specialized EPI teams that focus on priority population settings, including early care and education, or ECE, K-12, working with both of our school districts and private schools, long-term care facilities, working very closely with all 42 facilities in our county, and our community team works with other priority congregate settings that include close partnerships with our county jail and shelter providers, as well as other congregate settings, including transitional correctional housing, residential treatment facilities, and other non-clinical congregate settings. Our resource navigation and call center team provide multiple services. They provide linkage and supports and resources for people experiencing hardship during their quarantine and isolation periods. In recent weeks, the team has been supporting over 20 families per week with these services, and some situations require pretty complex follow-up and coordination. For example, supporting families with children who may be experiencing unstable housing or homelessness while they're also experiencing COVID and needing to quarantine or isolate. The team also fields calls from the public to provide information about quarantine and isolation, navigation, and supports to link community members. And I'll share some call center numbers shortly in a different slide. But in general, our team engages with community members impacted by COVID every single day. And we're currently operating 6 days per week with at least 1 lead epi on Sundays as well for any issues that may arise. And this work can be very rewarding and very challenging for everyone on the team. We experience a variety of challenges, working with families who are experiencing grief and loss from losing a family member to COVID, or who have family members who are hospitalized. We're also often the sounding board for public frustrations, or we directly encounter resistance to the work that we do, including folks who refuse to engage with our case investigators. But thankfully, our team has mostly positive interactions and reception from the public, and our team remains very engaged and committed to the work. It's a really strong team, and I'm really proud of every single person on it. We're all very grateful to have the opportunity to serve and support our community to address resource needs and prevent disease transmission. And that creates a very tangible sense of the positive impact that our work has in keeping our community safe and healthy. Next slide, please, Lexi. Since our case activity is reported in the surveillance slides that you've already seen, the only data slide that I'm sharing is this one, which represents weekly call volume in the recent months. In the last 3 weeks, you can see some large increases. This is primarily stemming from vaccine rollout changes, including boosters and the newly approved younger age groups. About 40% of calls in the past 3 weeks have been about vaccines, mostly general questions and requests for support in making appointments. And last week, that 60% of the calls were in that category. Other top categories that we see are questions about businesses, schools, and events, or questions about exposures to COVID or masking, and several other different categories, but those are the most common. Next slide. So our epi team needs to remain responsive to the different transmission levels that we're experiencing. We use the levels outlined on this slide to plan our operations for case and outbreak investigation and for contact tracing. Our resource navigation response remains constant pretty much at all levels, and our call center operations can also be influenced by factors outside of this table, such as the updates to vaccination rollout that we're experiencing now, which I just mentioned, or other changes in the landscape that can increase call volume. In this table, we roughly lined up the Colorado Dial 2.0 iteration along with the CDC transmission tracker and the county's response and recovery operations or ProBOCO planning phases. And we also included a general epi determination. The bottom row outlines the containment impact that our epi operations can have. In an earlier slide, Lexi shared the threshold, graphically for when we're experiencing case rates that trigger our surge response. We've been in surge since late August, and during a surge, we focus our resources on the priority groups that I mentioned earlier. And when transmission levels are lower, our operations have a higher impact on containment. And once we reach lower transmission levels, our epi activities really become critical to sustaining containment or hopefully one day achieving suppression. So that is all I have prepared for you today, and I'm happy to answer any questions you may have or pass it on to my next team member, colleague.
Carol, go ahead, Morgan.
Oh, no, I just wanted to say thanks, Carol, so much for all the work your team is doing and for fielding all those calls and really, most importantly, for supporting the most vulnerable in our community. So thanks for all the work your team's doing.
Thank you. Thank you so much. Any other questions?
Thank you. And so with the current case rate, and I think it was about 275, if I remember earlier, per 100,000. How is that impacting the contact tracing CICT team? Is that beyond their capacity? Are they okay? I'm just curious.
Oh, it is. We're definitely beyond our capacity to be able to reach every single case or every single contact. So we do prioritize case investigations and contact follow-up so that we're focusing our efforts in the higher risk settings and groups. So we want to make sure that settings, folks who are in residential facilities that are higher risk, or associated with schools or other settings that we're trying to make sure we keep transmission out of places where people congregate in that sense. We're focusing on those. And I see a couple more questions. I see Lexi, do you have a question?
Just to provide a little more context, Carol's modest, so she won't mention this, but the system that they have developed for prioritizing cases is actually held up as a model in the state. I don't think that there's a county in the state that can operate at the full capacity that they would like to be able to serve the community right now. And so every single county is in these kinds of surge conditions. And the system that Carol and her team developed was actually recently highlighted and promoted as one that other counties should adopt.
Thank you, Lexi.
I see another hand. I don't recognize who that is. Amber?
Yes, I have a question in regards to transmission. Is there any data about how much transmission of COVID is being done by people who are vaccinated?
I'm sorry, can we have clarification on who the speaker is?
Yeah, I mean, this is for board and staff to, this is not a public comment period. So Amber, I don't know if you're on staff. I don't think you are.
No, I'm not. That wasn't made clear to me that this was just a board thing, so good to know.
Yeah, for this part of the agenda, this is a Q&A between board members and staff.
Okay.
Thank you. All right, that was my question, was CICT.
Okay, thank you. If there's no further questions for EPI team, I will pass it on to Keith Rawls.
Hello, everyone. My name is Keith Rawls. I'm the program coordinator for the immunization program. Thank you for having me tonight. Boulder County Public Health is embarking upon vaccinating 23,500 children ages 5 to 11 that are eligible. The goal is 14,000 by January 31st. We got started on this effort on November 6th, on Saturday. We vaccinated 171 kids. It was well received. The parents were highly motivated. It was a very celebratory type atmosphere, fit for children. We had a lot of activities for the kids and a lot of gifts for them for undertaking this vaccination effort. We're also conducting equity clinics at the Longmont Hub Thursday evenings, 12 and up, and Friday and Saturdays are pediatric clinics. And some parents are receiving boosters as well. As on Saturday, 44 parents received a booster shot during that clinic. Long term, we look to integrate the vaccine for the COVID vaccinations into the vaccine for children and equity clinics going further. We also are conducting vaccination education efforts and focus groups for our youth, for parents as well. And we also are undertaking the flu vaccination campaign with the Westview Presbyterian Church, the Round Food Pantry in Longmont. We were asked to come out to provide flu vaccinations tomorrow. So we're really excited about that. That's a partnership that's been a year-long effort. So we also provided a COVID clinic out there as well at the Round Food Pantry. And on September 18th, we conducted another community clinic with a partnership with the Latin Chamber of Commerce for their inaugural Fiesta Food Truck event. It went really well. So we're engaging the community of Longmont where there's a great need. Any questions? And this is the last slide for me. It's the hand painting section after the observation period for our kids. I candidly call it Hands of Hope. Hope for reducing the spread of COVID in our community, and hope for reconnecting with extended family during our holiday season. Questions?
Thanks, Keith. It's good to hear the initial response to the 5 to 11 vaccine. I guess the sobering point is that it's going to take probably several months for everybody to get their 2 doses, and then for that final immunity a couple weeks after. And so while it will likely help starting at early 2022 for the population at large, it's still, we still have an uphill battle in front of us.
Absolutely. Thank you, folks.
And good evening, everybody. I am Carrie Middleton, and I'm an emergency management planner with also the Communicable Disease and Emergency Management Division. And yeah, also happy to be here. So a couple of things I wanted to talk about tonight. One is kind of to that point that was just mentioned, is with respect to those vaccinations for the 5 to 11-year-old age group. We have been working on a plan to help foster access to those vaccinations throughout the county. So part of that plan has involved meeting and coordinating with providers so that we can identify of the providers who is able to offer those vaccinations to the 5 to 11-year-olds. We have 67 enrolled providers, and we do have information on our website to make that information available to the community so that they can schedule appointments. Through that coordination process, and this was alluded to briefly by Keith just a few minutes ago, it looked like a potential gap in vaccine access was in Longmont. And so part of identifying that gap is what was driving that decision to have those pediatric vaccination clinics at the Longmont Hub Fridays and Saturdays. And those are going to run, at the moment, that are planned November, December, and January. And we do, of course, continue to work with our community ambassadors to help ensure that priority populations do have access. Lexi, you can go to the next slide. Thank you. So I know equity was mentioned earlier, and as definitely something that we center in all of our work. And the model of equity that we are using in particular our vaccine equity work is really that model of power sharing, of having it be community-led and having it be grassroots. And so that involves that co-developing and implementing plans with our community ambassadors, as well as working with community influencers and cultural brokers. We're also coordinating with the Boulder Valley School District to offer a number of clinics that are actually coming up this Saturday, November 13. Those clinics also have a pediatric focus, so special focus on that 5 to 11-year-old age group. And this is also part of our access strategy. These are also equity clinics. So we also have coordinated with the school district to choose sites in particular that are accessible to priority populations. We are also working with St. Vrain Valley School District to explore the possibility of having a pediatric vaccination clinic at Timberline K through 12. And right now are working to identify a vaccine provider for that. Next slide, please. And then another area that we wanted to share with you was the work that we're doing on vaccinations for teens and young adults. So Lexi had mentioned earlier that we are seeing in our communities lower vaccination rates for those ages 18 to 29 or 30. So that really speaks to the need to really focus on this population. So to do this work, we are collaborating with our community health division. And there were a couple of things I wanted to mention. One is that we did meet with community ambassadors, including youth who work with those community partners, about what they were experiencing, what they were seeing with respect to vaccines and teens and young adults. And it was a really wonderful meeting in the sense that we could hear directly from youth, who after all are the experts on youth, and we could hear directly from priority populations. It was also a disappointing meeting in the sense that the information that they shared with us is that there was a lot of vaccine misinformation on social media, as well as a real potential for bullying when folks might take a more pro-vaccine messaging in social media. Something else I wanted to mention is that we're also hearing from our community health colleagues that as we look at addressing vaccine hesitancy in this group and vaccine education, we need to really do that in tandem with considering and addressing mental health challenges as well. So looking at a whole person and not just a person who might or might not get a vaccine. As when we think about young people who might be experiencing health challenges, they might or might not be able to be in a position, given those health challenges, to even think about getting a vaccine or not. So we're incorporating that element into our work as well. The work, we really do intend to be youth-led, again, as the youth as experts kind of in this realm. And we'll continue to work with community ambassadors with a special emphasis with this population on communications, outreach, and social media. So that's kind of a quick update on some of our vaccine equity work. And that is the end of what I have prepared. So if there are questions, I'm happy to answer them.
Not a question, just again, a thanks to all the focus on equity and the prioritizing of populations within your work. So thank you.
Thank you.
Okay, does that do it for the Boulder County staff presentations?
It does. That concludes our presentation. Thank you.
Okay. As always, a lot of information. Still pretty sobering, unfortunately, because of the seasonality, but also the fact that we got 70+% who are vaccinated and we're still having challenges. So, I mean, I just don't see that the data, hospital data, projections, case data, test positivity rates, none of that is saying to make any changes to the public health orders. So I just, I mean, I get it, right? We're tired, we're frustrated. We just want things to go back to 2019, but they're not, and therefore, we're not obviously getting the transmission control that we were certainly 12 months ago when we went into our fall winter surge. And so I just, these numbers are very sobering. And if anything, every model run by the School of Public Health seems to extend that peak out further and further. And so kudos to everybody. I understand the frustrations, but there's just no data that supports relaxation of any of these public health order. Any other questions or comments from the board?
I'll just second your comments, Greg, that, I think that we are so appreciative of the staff running all the data and presenting all the data to us that helps us make informed decisions in terms of public health orders. And, the comments I hear most often are frustration around masks in schools and kids not being at as high a risk for COVID or adverse outcomes from COVID, but they are such an important part of us controlling transmission in our community to protect the more vulnerable folks who are in our community. So I think sometimes we at the board don't always respond to every public comment that comes in, or especially those folks who are feeling really frustrated. And, I would echo again, Greg, what you said. We feel your frustration, and and I just want to assure everyone, we really don't want kids in masks indefinitely. I think that, or I don't want kids in masks indefinitely, but we are trying to protect the most vulnerable in our community by bringing those transmission rates down. So thanks for everyone who is in this with us in the community and protecting our community as best as we can.
Yeah, and this is Lindy. I'd also like to echo these comments. I think it's important that we're really looking at what's going on around us right now. It's critical. I would also just like to thank our community provider partners for all they're doing right now in very tough circumstances where our capacity is literally at its limit. And we're hearing that, locally, but also statewide. It's a huge issue. And I think that potentially some people don't understand how critical it actually is, even in getting critical services, not just elective services. So these are the things that we're trying to avoid in some of the measures we're taking. And I think we often do not talk about our healthcare system enough, which is critically important. So thank you for those comments, board members. And then I do have one question on the executive director report that I'd like to ask. I don't know if that's the time for this or not, but I'll hold my question until we're moving on.
Yeah, that's a good segue. If nobody else has a closing comment on item 3, we'll move into the director's report.
Thank you, President Thomas. I don't have anything in particular to highlight in the director's report other than what an amazing summary that I'm sure does not capture all of the work that continues to be effectuated, implemented, in spite of all that we just showed you, where our teams are stretched and at capacity. I just find it absolutely amazing. Every month when we ask for input from our teams for this report, I continue to be amazed. I know the work is going on, but when you see it written down, it's just truly amazing. And I'm so grateful to everyone at Boulder County Public Health that is pulling in the direction of protecting and promoting the health of the people of Boulder County. So with that said, and since I don't have anything particular to highlight, because I'm certain you've taken a look at it and there were so many things contained therein, I will leave it back over to you, President Thomas, to facilitate questions that we can hopefully answer.
Lindy, why don't you go ahead with your question?
Okay, great. I'm trying to get off mute. Absolutely. And if we can't answer it tonight, no problem. I just wanted to know a little bit more about the substance abuse intervention program. Sounds like there's a transition going on right now to mental health partners. Wanted to get a little bit more in detail in terms of how that transition is going and what the time frame is for that transition.
I'd be happy to tell you a little bit more about it, and if needed, we can always connect you offline with the supervisors of that program. So our staff has been really rolling up their sleeves and meeting with mental health partners to share our best practice implementation, documentation, program parameters, so that the success that we had in implementing that program inside BCPH can hopefully be replicated to the same extent with our community partner mental health partners. I believe that the program staff let me know, because I was involved in some of those initial kickoff conversations, that it would be into January of 2022, where hopefully everything would be in place. And I'll say that, we're not the contractual provider. It is actually our Boulder County Department of Housing and Human Services that is taking on the contractual requirements. And so we're not involved in contract negotiations per se, but rather best practice provision, sharing of all of those pieces of the program that worked well for us. So we can certainly continue to give you updates, Member Hinman. And if you need more than that, we're happy to connect with you.
No, I think that's great, Director Rodriguez, and just having, I think, more regular updates on that transition would be great from my perspective. And then the other thing I wanted to ask about, because I have personal interest in this, and we've discussed this in terms of areas that I'd like to help support as a board member, is the climate action team and your new lead, Grace Hood. I would love to personally understand more about that area of the organization and what Grace is doing to, quote unquote, reinvigorate the team and the work going on in that area.
I'm not sure if Joe Malinowski, who is the division director in that area, is on tonight. Dr. Nolan, this is one of your areas where you take leadership within the organization. If you have anything to add, otherwise we will certainly, Member Hinman, always, as promised, get back to you and either bring a presentation to the board together or connect with you individually. Dr. Nolan, do you have anything to add?
Sure. We are super excited to have Grace on board with us. She comes to us with a journalism background and a real passion for climate change work and real interest in creating change on the ground, not just reporting on it, as she says. And she has really jumped in full force to understanding what the work before her has been in the county and where our opportunities are. She's working with a number of colleagues, both across the Environmental Health Division and also across our agency, to really identify some spaces where we can see some really deep community action with an equity-centered focus, and also how we can begin to embed climate change action considerations across programs in our agency, which is one of our strategic priorities for Boulder County Public Health. And she, along with other folks on the air quality team, will be working quite a bit with our county colleagues that work in climate change and sustainability spaces, which includes a number of people who were previously Boulder County Public Health employees and who moved over to the county. So we're looking forward to seeing some of those collaborations, as well as moving into some policy spaces in coordination with CALFO, the CALFO Legislative Committee, and MDPH.
That's great. And I'd say the more you can bring to the discussion around the evolution of this would be fabulous from my perspective. So thank you.
I had a question on the leadership hiring. So Director of Strategic Initiatives was Susan. So that was April, May. And then who was the last director? I know I should know this. So this, and it's like, I have COVID brain. So who was the last Director of Administration and Finance? Is that Megan?
Megan Hatton.
Okay, that was Megan. Okay. So that's been a while. And so, yeah, I mean, kudos to the person or people who have been filling those shoes for 6 months or more. I really hope you get some good candidates in there soon.
Dr. Nolan and I hope for the same, and I know the teams are excited about this as well. So yes, we're hopeful for a successful recruitment.
Okay. That's all I had.
I just want to say a big thank you to Indira for answering my question from last week and looking back at the Arizona schools to see if they took into account their quarantine procedures at all. It's too bad that they didn't, but thanks for passing along the reference and the answer. And then I had one question. So I was reading a couple days ago, I think, about a shortage or a strain on naloxone supplies throughout the country. And then Denver also was reporting a shortage of Narcan. I was just curious if we're seeing any of those same issues in Boulder, only because I noticed it was mentioned on the Works debrief about the kits that they've distributed. So I was just curious if we're having any shortage or strain.
Indira,
yeah.
can you take that one?
Yeah, thank you. The naloxone supplies, I think there's just been a shortage of being able to obtain them. I know that Georgia Babatsakos, who is our harm reduction coordinator, is working to do a large purchase of naloxone before the end of the year to make sure that we have enough naloxone to hand out. You've probably been following that there has been an increase in the number, the drug enforcement group here in Boulder County has been reporting. There's been an increase in the number of pills that have been cut with fentanyl, which is super deadly. And so we're trying to make sure that we have enough naloxone to be able to hand out to our syringe access participants. And Georgia could give more information if you would like that. And in terms of, I think there was a question about the SAIP program transition. That was a program in transition prior to the pandemic, and we are just now in the process of moving that over to Mental Health Partners, and they've been a really, really good partner in taking on early intervention. That's not been something that they have, stepped in. They've done prevention intervention, and so this is just adding to the ability for us to take all of our diversion efforts and centralize them into one place at Mental Health Partners. And so we're excited to see how that transition rolls out.
Any other comments on director's report? Going once?
Nope.
Okay. Then old and new business. Anybody have anything for the good of the group? Nope. Okay, me neither. All right, everybody. Meeting adjourned, 7:02 p.m. Thanks again, everybody, all the staff who contribute to these reports. Greatly appreciated. A little bit overwhelming, but hey, good thing we only do this once a month here. Okay, take care, everybody.
Thank you,
Thank
board.
you, everyone.